The EMS Avenger podcast is sponsored by Zoll.
More and more today, our students are getting their content from online, and they're getting it from 30 to 60-second reels. Kind of here's the top two or three takeaways from something that just published. And the way that these algorithms are written, it's designed to reward things that might be a little bit more controversial or definitive or confident rather than accurate. And so they're consuming this content at crazy high rates, and then they think that that is standard of care.
I'm Jimmy Apple. This is the EMS Avenger podcast, and I am here with Dr. Brandon Morshedi. Dr. Brandon Morshedi is a physician at large on the National Association of EMS Physicians. He is a medical director. He is still a practicing physician. In fact, he is responsible for so much that I even don't really understand where sleep or family or recreation come into that at all. Tell me, we were talking about what all you're involved in. Just give me a little bit of a rundown again of all those things that you're responsible for.
Of course. So trained as an emergency medicine physician. So, of course, I work plenty of clinical shifts in emergency departments around my state. I've got level 1 trauma centers all the way to level nothing critical access hospitals. Love the variety. That's the clinical side. And on the EMS side, I'm the chief medical officer for a large public utility model service here in Central Arkansas. So it's the transporting ambulance entity plus 35 first responding fire departments, altogether about 1,100 providers. And then I've got 13 helicopter bases that I oversee as part of a GMR with the Aerovac Life team, and then 55 state parks and lots of park rangers, a lot of kind of wilderness medicine, EMS stuff. And then our state task force oversee about 225 members of that. So we've got a large FEMA Type 2 urban search and rescue team. And
And this is
that's
the state of Arkansas, right?
all in Arkansas, yeah, except the helicopters. I cover some in Texas as well.
And I visited Arkansas earlier this year, and we had dinner together. And it was a state that wasn't really on my radar as far as anything that I was going to make a special visit for. And after visiting Arkansas, particularly in Hot Springs, where you're located, my mind was changed. It was a beautiful state, beautiful area. So definitely undersold as far as a destination state.
Yeah, it's our well-kept secret. We call it the natural state for a reason.
I want to jump in to talk about NAEMSP, the National Association of EMS Physicians. Tell me what NAEMSP actually is.
So it's a professional association or organization that represents EMS physicians and EMS professionals. Actually, about almost a third of our membership are non-physician members, but these are the leaders within the subspecialty of EMS medicine, kind of the movers and shakers. Of course, the majority of them being EMS physicians, a lot of medical directors, up-and-coming medical directors, EMS fellows. There's even some emergency medicine residents, medical students, and pre-meds that are involved. Most of the science that comes out of the researchers that are trying to advance the practice of EMS medicine, it tends to be funneled through NAEMSP. So they're the ones that are not only vetting the practices that we're currently doing, but trying to advance the practice, challenge dogma. We are a subspecialty of medicine. So NAEMSP, in my opinion, is kind of leading the way with advancing that subspecialty and giving people a platform to promote, publish a lot of that research and position statements and things like that.
A lot of people, I don't think, realize how much research is actually filtered and funneled through NAEMSP. I attended the NAEMSP gathering in Tampa in January, and one of the largest components of that gathering are the Menegazi abstracts, where people present emerging research for essentially just public approval. And people can, there was almost 200 abstracts present when I was there. And it was an incredible amount of research. And a lot of people put a lot of effort into bringing data for that annual presentation. If we have this NAEMSP and they have this influence and they make these decisions, what is the gathering of eagles?
So there's a lot of overlap with the EMS physicians that are kind of the movers and shakers, the more progressive faction of our subspecialty that are part of the gathering of eagles. It started in gosh, I think it started in Pittsburgh and then quickly moved to Dallas for about 20 years, and maybe about 50 medical directors from the largest cities around the country. It's now grown to there's well over 100, maybe close to 150 now, and it's international. So you have a lot of cities across the pond that are represented as well. And these are large system providers that are their problem today was someone else's problem yesterday. So they are sharing resources, solutions, creative thinking, ways to kind of tackle the tip of the spear when it comes to public health crises, taking care of patients in austere environments. And they meet weekly, virtually, and then once a year in person down in South Florida, and just say, hey, here is our most recent problem. Here's how we attempted to tackle it. Here's what worked. Here's what didn't. And then give all those tools to the audience members to take back to their homes.
Um, when these kind of like alphabet soup type of organizations are presented to the person in the field, it's hard sometimes for them to have an appreciation for what goes on there because they have very immediate problems right in front of them. They're overworked, they are tired, they're exhausted, they're suffering from vicarious trauma, mental injury, and last but not least is the compensation issue. And everyone wants to, or the inclination sometimes is to push back against anything that you're doing because we are not getting paid enough. How do you respond to that, and what kind of conversations happen within an influential organization like NAEMSP in
Yeah,
regards to that?
that's a great question. And, everything that we do and we promote and we say we should be adding this or a protocol or medication or equipment, there's a cost associated with that. And a lot of times medical directors like to think, or maybe they're told early on, clinical is this lane and operations is that lane, and the two lanes should be separate. But any good leader knows that there's a lot of overlap between those. You advance clinical practice, it's going to affect operations. You make a change to make operations more efficient, it's going to affect clinical practice. So a lot of these conversations are geared toward leaders sitting down at the table and talking unintended consequences of rolling out something new, something progressive. Certainly, we have to be cognizant of the financial implications of the decisions that we make. If I'm adding IV Tylenol for pain, for example, it's about 10 times more the cost of fentanyl. What can I, try to take away from the system or make more efficient to compensate for those costs? Or, perhaps I create some more treatment in place initiatives so that we can, bill for things that we're not transporting for. So there's a lot of simultaneous conversations happening at those roundtables with the leaders to try and constantly tweak the system to make it more financially sustainable and do the right thing for the patient. It's not a conflict. It's just a delicate balance, and good leaders are really good at that. And NAMSP equips their EMS physicians to be able to have those conversations.
I'm going to kind of push down on this a little bit. And I'm really only not putting you specifically in the spotlight. I'm not making you the avatar for EMS as a concept. But I just want to really push the conversation to something that's a little bit more visceral. Because what you just said, I don't think resonates at all with the average paramedic sitting in his base right now where somebody put this on YouTube. How present is the struggle of the field provider in the minds of physicians who are working to support the work they're doing, but also advance the field? How real are those struggles? And do those conversation happens? Like hey, we're going to put out a position paper that says every ambulance should have point of care ultrasound. Are we talking about how skill creep is becoming something that is not matching the rate of pay? Like, are we really, really considering how what we do impacts the field provider?
Yeah, I would, if I'm being honest about it, historically, I'd say no, we haven't been. And I think each year that I've gone to an EMSP, I've noticed in the pre-conference, the medical directors course, the 3-day pre-con that they do, where you have the EMS fellows and people that want to become EMS physicians, they take this course. There are so many more EMS physicians today that came from a background of working on the streets as a EMT or paramedic before. And I'd say, over the last 5 to 10 years, seen a really big sway towards physicians that still have those ties to working on the streets. Certainly getting a lot better than it used to be historically. Myself included as one of those 12 years on a 911 ambulance before becoming a physician. I'm well aware of the burden, the mental drain on just adding yet one more thing to have to know to do, to train on, to stay competent with, one more tool in my very big, deep, busy toolbox that I'm having to sort through when it comes to taking care of a patient. I think that physicians that have that background, and if not, then you're going out on the streets and riding with your crews and seeing what it's really like. That's how you stay in touch with them and really understand the impact that your decisions make on your crews when you're adding new stuff to their toolbox.
Sure. And, to offer the counter argument too, is that you have a specific goal in mind. The National Association of EMS Physicians has a specific goal in mind. We all have this specific goal in mind, which is we want to improve patient outcomes, right? Ultimately, we want to be better at our job. We want to have better resources, better tools, and better outcomes. And so we can't we can't sit on research. We can't sit on progress simply because the purse strings have not opened up for paramedics. Is that fair to say?
Yeah, yeah, absolutely. There are some things that are just kind of common sense. Yeah, we need to move forward with this and not wait on the prospective randomized controlled trials to be done to prove its benefit. But you still have to
What
kind
I
of wait.
really mean is that let's continue to use the example of point of care ultrasound. You can't just sit on a position paper saying, I think that we should all have point of care ultrasound for at the very least to uh, uh, confirm whether or not ventricular wall motion is present in a PEA arrest. You can't just sit on that position statement because paramedics aren't getting paid enough.
Right. Yeah. There are the right things to do for the patient, even if it's something we're not being reimbursed for yet. Yeah, these are the fights that we tend to have where we're trying to push for the right thing to do with balancing what it's going to cost us to get that done. And certainly you have to pick those battles pretty strategically to maintain longevity in this career on both sides.
Um, a position paper, say, like, there are a lot of position papers that come out from NAEMSP. I love actually waking up in the morning to a cup of coffee, looking to where I find my research and seeing a new position paper from NAEMSP. I mean, it's just I love seeing new thoughts. I love seeing dogma kind of like attacked. And I like seeing EMS being progressive. One of the position papers that was just released was one that was authored by Melody Glenn, co-authored by Remley Crow and some others, that advocates for EMS, all of EMS, to be able to have harm reduction programs, including the ability for all EMS personnel to be able to administer buprenorphine, which is a drug you administer to people who suffer from opioid use disorder to counteract withdrawal symptoms and then subsequently help them get into some sort of rehabilitation. These are programs that have been successful all across the United States. However, there is a lot of pushback from the people in the field who see that as actually going beyond what their actual role is as EMS. I don't actually share that opinion. I think that the role is however our community defines what the role is. But how do you respond to somebody who simply wants to clock in, respond to emergencies and fix emergencies, and then go home, and they don't want to be a counselor or a mental health professional or have to involve themselves in some of the dogmatic type of, not dogmatic, they have these dogmatic mindsets and they don't want to involve themselves in practices that actually contradict their dogmatic mindsets?
Yeah, another good question. Our mission objective number one is 911 response and emergency care, and nothing that is pushed out as elevating the scope of practice or the ceiling for care that we provide is meant to detract from our primary objective of 911 care. I think a lot of these position statements, and that one included, is more about raising awareness of the role of EMS, the important role of EMS in the healthcare system beyond just that 911 response. It's removing obstacles where a lot of these programs that have tried to develop around the country have met resistance. Putting out a position statement gives a resource for agencies that want to provide that for their community because their community needs that type of response or resource, can take it to their community leaders and say, look, this is supported at the highest level within our industry to remove these obstacles. Certainly, nothing that comes out like that would be a mandate that you must do this as an EMS agency. It's more about just providing support for the ones that do want to do it, removing obstacles, improving or I guess raising the scope of practice for them. And you'll see a lot of these work their way into the National EMS Scope of Practice update as the next update comes.
Another position paper that came out within the last year or so was the positions position statement on pelvic binders. That was an interesting one because it really divided people. There are a lot of people who are aware that the evidence for benefit for pelvic binders was almost non-existent. However, there are people who see right in front of them in the same way that they see the use of a traction splint immediately relieves someone's pain, which traction splint is actually on the chopping block, but there's something where they actually see literally someone being in pain and then suddenly not being in pain. And they see that as well with pelvic binders. How do you reconcile what people are seeing with their eyes as opposed to how the data is informing you?
Uh, it, I personally think it comes down to proper patient selection. If you put it on the traction splint on the patient that needed it, they're going to have the benefit. If you put it on the one that had a femoral neck fracture, they're not going to get any benefit from it. Same with the pelvic binders. You put it on somebody with a broken hip, you're going to make them worse. You put it on somebody with the open book pelvis, they're going to have some hemodynamic benefit from it. For me, it comes down to patient selection, and that's that kind of clinician mindset versus technician thinking, where they're just putting it on because they're having some pain when you push and squeeze on the pelvis a little bit.
But some of there's some subtlety there in what you're saying, but some of that subtlety is lost in these position statements. And for people who don't have the benefit of having like an entire paper sent to them and they're just hearing it summarized, all they're hearing is, hey, we just don't see evidence for benefit. And how do you reconcile the nuance of what you just said to a statement that says we just don't find them to be beneficial?
That's, in my opinion, the role of the medical director at that agency to be able to yeah, kind of take those conversations that they're hearing, take the punchline, that was put on social media, and help curate that content to teach in that system. Maybe it's, hey, we're going to de-emphasize pelvic binders in our system, but we're not taking them completely away. Let's talk about patient selection. That's on the medical director and the educators and leaders of that agency. Otherwise, if you're just reading, I don't even call it abstract medicine anymore. What you see on social media is just the punchline at this point. And that's on me. That's my responsibility to talk to all 2,500 of my crew members that I oversee when they're flooding me with, "Hey, I saw this. Looks like we're getting rid of this thing that I thought was great." And like, oh boy, work now.
Are you saying that I've caused you problems?
No, sir, not at all. You actually, follow the science, and you share your resources and encourage people to go and read the source, which I appreciate.
We're actually going to get into that soon, but I'm not done talking about NAEMSP yet. If you could put out a position paper right now and everyone within NAEMSP signed on to it, or you could put out 3 position papers, it's dealer's choice. What would be on the chopping block and what would be added?
Ooh, man. This is just Brandon. I can't speak for NAMSP, of course, but
Understood.
I am a huge proponent of elevating our clinician mindset, our critical thinking, and going back to what we were talking about before, going towards this kind of EMS 3.0 mindset where we move beyond just the traditional 911 response. Because I mean, financially, there's a lot of services that are doing that and struggling and looking to expand their ability to capture revenue. And you're starting to see a lot of push for initiatives where EMS is seen as the valuable missing puzzle piece in public health and community healthcare infrastructure. And that will come with developing a clinician mindset where, you don't have to go get a degree, but we shouldn't have to argue about whether more education is beneficial for you becoming that healthcare professional that you demand to be seen as. You can't just go get that technical certificate and then think that you're going to achieve that kind of clinician mindset, critical thinking. How you phrase all that into a position statement, boy, that would be that would be a fun one to write. But that would be top on my list.
What would you take away?
Um, a desire to be a lifelong learner, to seek out professional association memberships, learn how to read and critique literature, learn how
No,
to.
no. What would you take away from EMS
Oh,
practice? Yeah.
um, hmm. Um, a lot of the cardiac arrest interventions that we do are based on ACLS and in hospital interventions. Certainly, I think improvements in cardiac arrest, which if you look over the last decade, we're really not moving the needle a lot. A lot of improvements in cardiac arrest are going to come from pre hospital research and literature. So I would take away all thou must follow the Bible of ACLS in the
Mm.
field, or otherwise you're not following standard of care. That's got to go today.
Amen. Amen, brother. I will co-author that paper with you. Um, okay. Last kind of NAEMSP related question. There's been a lot of position papers out there where NAEMSP has actually taken a stance. We believe as an organization, as an industry, as the leaders of an industry, you should be doing this. We believe as an organization, as the leaders of this industry, that you should not be doing this. NAEMSP put out not a position paper on spinal immobilization. They just did not quite pull the trigger on a position. They just kind of let the authors have at it and said, hey, you can say NAEMSP, but we're not telling you what you should or shouldn't do. Uh, was that purposeful, or are we overblowing this? Was NAEMSP a little bit hesitant to really take a stance on spinal mobilization?
I think historically NAMSP, and I've only been on the board now for 5 months, just kind of seeing behind the scenes stuff. But when it comes to developing and promulgating these position statements, NAMSP is really big on collaborating with other professional associations. You'll see American College of Surgeons a lot on some of these, especially with a lot of the trauma compendium papers that just came out. You'll see, especially for some of the more operational stuff, really heavy on American Ambulance Association, NAEMT, IAFC, IAFF, and others. So lots of collaboration. This one in particular, I think that there was a lot of feelings behind this, where some people felt very strongly that just like with backboards, a decade ago, we knew those were harming people. We also have some evidence, a good amount of evidence, showing that just indiscriminate use and prolonged use of cervical collars is also causing harm. But we don't have as much evidence showing that it's not uh, preventing, I guess, injuries or worsening of injuries. So there wasn't as much definitive evidence on this one as maybe perhaps the backboard one. I think it's important to have this conversation, which is why it was important to publish that position statement. There are a lot of services that are de emphasizing cervical collars, looking at their own data, working with their partner trauma centers, looking at what the sensitivity and specificity is for that EMS service, applying or not applying cervical collars, if they're getting it right, if they're using Canadian or Nexus rules on their protocols. It was a very timely position statement or statement to paper to put out.
You heard it
Uh,
here.
yeah, it was very timely to put out. We need to be having these conversations, but I don't think some of our partner associations were ready to jump off in the deep end with us on that one yet.
All right, transitioning from NAEMSP. Actually, we have a good segue because at NAEMSP, you delivered a presentation, which was on the learning that takes place on social media. Um, and you showed me a lot of your slide deck and showed me what you're presenting on. I watched the presentation, and it was really interesting because this is something that is really not it. There are some discussions about the education that takes place in social media, and not ducking the role that I play in that as well. Um, Tell me a little bit about what your thoughts are on social media education, uh, and a little bit of the content from that presentation.
Yeah, so the traditional classroom model, it's still around. I mean, I'm medical director of our own in-house EMT and paramedic schools, so we do traditional classroom didactics. But more and more today, our students are getting their content from online, and they're getting it from 30 to 60-second reels. Kind of here's the top two or three takeaways from something that just published, and the way that these algorithms are written, it's designed to reward things that might be a little bit more controversial or definitive or confident rather than accurate. And so they're consuming this content at crazy high rates. And then they think that that is standard of care because that's where they heard it. A lot of the ones that are doing it, like you and Peter Antevi and Jeff Jarvis, they share their resources, they share the pros and cons, look at both sides, challenge people to go and actually read the full article, and that's the part that helps us out. The part that's just like, hey, we should go back to mask pants because they used to save people. And, here's a letter to the editor. Like those are the ones that cause me a lot of grief, and then I have to spend a lot of time with. Medical directors suck at being in that space and looking at what their crews are consuming and being available to their crews to help them put all that into the proper context for what it means for our system. Or is that good science? Or no, that was actually just, kind of garbage opinion article. My challenge in my talk was to get medical directors to actually engage in that space. If not just producing, not everybody's going to be out there producing this content, but at least to pay attention to what's coming and help
I
their
think
careers.
that's a very salient point, which is that how many medical directors do you think that there are in the U.S.?
Oh my goodness, 10,000, maybe
10,000. Wow.
more.
Uh,
Yeah.
and we could probably name three or four of them that are making content for social media. And
Yeah.
even then, most of that is really just kind of not really front and center. Peter Antebi makes some content. He is making some reels now. But I mean, he's all over social media, though, whether it be a webinar, that sort of thing. I mean, his message is getting out. Jeff Jarvis's message is getting out. But where are the medical directors who are talking about these things and engaging in online debates and engaging in breakdowns of why this practice may be good for this service, but it's not good for this service? It's that's a really interesting perspective right there, is that the medical directors are absent from this social media conversation.
Yeah, and our crews are consuming it, and then they're gonna go out there thinking that, well, hey, my medical director's out of touch because his protocols don't match what I heard should be the standard of care, and it can create some distrust or kind of discredit a medical director if they're not front and center in those conversations. I'm with my crews all the time. I see them in the hospitals. I'm over here in the classrooms. Luckily, my agency takes care of me and allows me to be here more frequently. But I'm always asking my crews, "Hey, tell me about something you've read recently that you want to talk about, or what's a reel that you saw in the last few days that you want to try here? If there's something new that they saw." So I may not have time to actually, go swiping through the reels and algorithms myself, but I'll go to the crews and ask, and that creates that kind of psychological safety where they can come to me and be like, "Hey, how come we're not carrying blood here?" "Well, that's good, Chris, and let's actually talk about some of the obstacles here, and how maybe we can work together to overcome these." So I create that safe space for them.
How routine is it for you to get sent reels from crew?
Weekly, I get a lot of reels and podcasts get sent to me, and because I've worked for years here to try to create that safe space for them, I've opened that door for them to send me things, and we actually create journal clubs here where we have conversations. We'll take that reel that talked about that article. We'll take that article and read it, break it down, and talk about why it's good science, maybe what some of the limitations were of it. Again, trying to teach my crews that clinician mindset, how to critically evaluate literature.
I just want to take a second and applaud you for that, because medical director involvement as a whole is so important in
Mm.
how successful a service can be. If you don't even know the name of your medical director, how could you possibly be actually out there performing, you know, evidence-based best practices without actually having conversations with your medical director about what those are? But to go beyond that, to engage your crew in research and to engage your crew with the reels that are out there, with the data that's out there, with the education that's out there, and kind of getting into the nuts and bolts of that, and what's valid, what's not valid, what's effective, what's not effective, what's relevant, what's not relevant. That is so important. I'd love to see more of that around the country. Um, how much of a source of consternation can it be, though, for you when you simply just get a reel that, hey, EMS Avenger says you're dumb, which I've never said anything like that, but just kind of that's the gist of the message that you're getting.
Yeah, surprisingly, I see it as a positive. It keeps me on my toes. It keeps me focused on what's coming out there. I see it as them sharing with me what is trending right now, or what's hot out there, so that I don't actually have to go and spend time looking for it. So they're doing me a solid by sending it to me. And then it gives me something to go read and, okay, what am I missing here? Are my protocols and guidelines up to date? Oh, actually, this is a really good paper here. All right, let's evaluate updating this guideline. So I see it as a positive. It's my crew is helping to make our system better. So I mean, it's a little bit of work for me, but it's good work. I don't mind at all.
Have you changed any practice or protocol because of like social media content?
Uh, we're working on a lot of pain management stuff right now. Um, a lot of NEM squat measures. I can't think of anything specific from no, nothing off the top of my head specifically from social media. It does generate a lot of good conversations, and most of those end up with not really a "here's why we can't do that now." Here's just why we can't do it yet, and here's the
Hmm.
obstacles we need to address together and work on. Um, and we're pretty progressive around here in my agency. Maybe we should be the ones putting out some some reels.
I was thinking about that when you said that. I was like, if you are an open-minded person, like I know you to be, the notion that you wouldn't get pushed in one direction or another by some sort of social media content that's based in evidence and best practice might suggest that you are a very progressive service already. I think the struggle that maybe a lot of services and medical directors have is if they aren't really engaged in best practices and they're constantly getting bombarded with feedback from crews who are seeing it somewhere else. That's probably got to be a struggle in those areas. Um,
Yeah.
when it comes to education, do you think that we are focused way too much on the hours and not focused enough simply on the reinforcement of concepts? Is there a correlation between the hours that you get in education and your ability to put those concepts into practice?
Unfortunately, not as much of a correlation as we would like. There is a focus on hours, and I see it every year between January and March, with when it's research season, where people are just taking some shrink wrapped refresher course just to check the box for hours, and they only learn things that were in the textbooks in the past, and nothing new, nothing challenging. I actually, a couple years ago, completely revamped our education here, where I do quarterly grand rounds, and I use that terminology very intentionally with grand rounds, taking it from the field of medicine, where we are producing content for our crews that is, kind of advanced, progressive, based in literature, new stuff, challenging the way we've done things. I share with them our own data and constantly tweaking our protocols to reflect the way we should be doing things or updating things to be better at what we do. And it's gotten great feedback around here. Our crews feel like they're actually advancing their knowledge base and their skill set. We do focus on some of the foundational things as well, but we're challenging them. My EMTs are learning advanced, ventilators and surgical crikes so that they can be better partners for their paramedics out there in the field. So um, we're not just staying within their own scope. We're teaching them things much higher level, even though they may not be actually physically doing them with their own hands out there. But yeah, we got to get beyond just I got to get my hours in from my research, and how can I make myself a better clinician?
Sure. I mean, suddenly, like cramming 40 to 6 hours of online content, like the third week of March, it could surely not be creating better EMTs and paramedics.
Yeah.
So I would love to see us get beyond the notion of this time gated content and get into something that actually reinforces understanding of concepts, understanding of pathophysiology, even a situation where maybe instead of having to fulfill 60 hours of online learning where you have a video playing in the background while you're surfing the internet, maybe you could write a paper where you demonstrate critical learning concepts of the different areas where you're supposed to be able to demonstrate competency, and then incorporating micro learning as well. Like if you've
Mhm.
heard a couple of videos or reels reinforcing a concept and you can demonstrate that you've learned that concept and you've learned it in somewhere between 3 to 9 minutes rather than 30 to 90 minutes. I'm not sure why we are holding you hostage to a video screen.
Right. Yeah, we produce short content. My service is Metropolitan EMS, so MIMS. It's the MIMS Medical Minute, and we'll produce these short little videos, 3 to 7 minutes at the most. And then over time, as you do these and you knock them out, there's a couple questions at the end you have to do, just so I know you took away what the main points. You get CE hours for those over the course of the year. So those are ways that we're trying to fight the original dogma of having to sit there and just do 60 hours across
I
5 days.
love that concept.
Yeah.
Yeah. Dr. Morshedi, we've reached the end of our time. I appreciate your willingness to be open and vulnerable and to kind of take these head on and speak about the process that goes on at NAEMSP and what goes on behind the scenes as a medical director.
Thanks for having me, Jimmy. I appreciate it, and I appreciate what you do, man.
Thank you. I appreciate that.
Dark clouds rising black and gray, screams of chaos where we lay. Lights are flashing, calling the brave. The